So we have been, for the past 1.5 days, we have been loaded with how to treat the patients. That was nice to hear that different guidelines, how to update ourselves and everything. But all the treatment guidelines that has been presently given has to be put into practice. That is, from sick patient to well patient, when all the processes are happening, then obviously we have a chance of getting into a error of treating these patients. How to detect these errors? This is what is the most important thing that comes into the mind. Whether if there is an error, it usually we have different steps. Like previously, Dr. Sansi Arora has clearly explained how it goes around the simulation, then the second physics check, chart check, and so many things are happening. And we always in radiation oncology give more priority to think about machine quality assurance rather than giving it to the patient. How do we really get into the quality assurance of our treatment plan check? Most of the errors happen in the treatment planning setup, whether it is from the treatment planning, right from simulation to contouring to planning, and for execution, there are different steps where it is error prone. So Yale School of Medicine, Dr. Talcott has decided to do a blinded prospective study of a problematic plan detection during physician chart rounds. So how common is the errors? In radiation oncology, it is reported, academically it is reported 1 in 200 patients that there is the common error which is happening in radiation oncology alone. So is it really 1 in 200%? Probably it is underreported because of a general culture of not reporting or underreporting most of the errors happening in different fields. So the most significant errors happen in radiation therapy planning steps. So what happens? Radiation, as we all know, radiotherapy has its own catastrophic consequences. It may result in huge side effects, or it may result in an undertreatment and a chance of denying a cure to the patients getting treated. So physician peer review, they have found different steps. There is a physics chart checking, and then pre-radiation treatment review, pre-radiation treatment chart round checkings, and there are different steps. In this, they have found out whether chart rounds is really creating an important role in doing a quality assurance check in the treatment planning setup. How can we improve the peer review is the further things. So studies of peer review there is a doubt whether this chart rounds is really demonstrating an efficient way of doing the QA. The doubt comes from the background of peer review in other departments have been 30 to 8, at most 40 to 70% has been reviewed. This can be because of the other department reviews can always be done. We have seen that other department experiences like radiology reports can be reread by the peers, and the pathology reports and the submitted academic journals, and the radiation pre-treatment plan reviews by the physicist. So for example, Gopan et al., there's an article which has been published which checks about the second physicist review. Always a physicist auditing happens. Second physicist auditing happens after the plan presentation. So this, you can see in this example, the patient's isocenter shift has been entered in the system as no right and left or no adjustment needed, whereas actually if you see the error in this treatment planning system, there was a millimeter of differences which has occurred. So Gopan et al. Has found out 67% of the errors can still be checked by second physicist error. But what is the percentage that happens with quality of chart checking around quality assurance is only 40%. So the challenge is why it happens, because in the charted round performance, it happens around, even if it happens for 1 hour, for a busy scheduled department, there will be n number of cases. So there is a time constraint, competing priorities, which is the priority. So many cases and the interruptions that happens for a clinician when they are attending this, cognitive bias, because our attention goes down when as the time goes down, a number of cases increases. The treatment complexity, for example, to just guess around a rapid arc or IMRT, a complex treatment field, just sitting in the chart rounds may not be easy for identifying a problematic plan or an error has happened. or there may be a non-standard formatting. For example, not all clinical details are entered properly before simulation is taken for simulation. And then there may be a culture that, see, we have a culture like everybody is posted in different department. A person is posted in simulation, the other person contours, other person looks into the plan, and finally everything should be formatted. The person into the simulation may not even have the clinical details of this patient. For example, if I'm doing a cervical spine, we may not know which vertebra and how much is the epidural extent or soft tissue extent to really do the extent of the CT imaging. From there, the error starts. So as a result, chart rounds likely also can have error detection rates. And most of the time when we are doing, it depends on, sometimes the clinical presentation details are not available and we rely on our memory when the chart rounds are happening. Of course, the last and most important thing, when we have too much of workload, we should always remember it is also the fatigue that causes the chart round performance to be little lesser. So as a result, chart rounds likely also has only 40 to 70% error detection rate, and it is not a foolproof technique. So the objective here is to find out if we intentionally put some problematic plan, how much does the chart round really detects these things. So what were the actual factors that were affecting the PP detection methods? So the methods of doing this study was including a physician, physicist, and a dosimetrist, and 20 problematic plans were created and inserted into the chart rounds. And believe me, these all had a potential to cause a harm when it is going to be neglected, ignored, and going to be treated with the patients. So inserted PPs were inserted randomly and the chart rounds were extended for 1 hour, and the study extended for 9 weeks. And the problematic plans were not done in such a way that it had a 95% detection rate. So the methods, and also what are the different varieties that we can put this problematic plans as? Either it can start from imaging, as I've already mentioned it, or it can be because of the contouring or planning quality. That can be only of two systems, either from the planning or from the imaging system. So further, if it can be classified, then it comes from different sets. Other than imaging, next step will be obviously target contouring. So it can be a wrong contour, or it can be a wrong side. Laterality can be, or the normal structures have not been identified and not been spared. Inadequate target coverage, dose and fractionation pattern can be incorrect, and the previous treatment may not be considered. So in this, the plans were reviewed from the Eclipse and Mosaic systems, and the plan and images, obviously, after the study has been reverted to the original state because the problems were created. And see, for example, in this patient, we can again discuss this imaging set was not sufficient. Probably during the simulation, the details were not sufficient enough available for the person doing it, that the cervical spine data was not sufficient enough to cover the target volume. In this case, the patient's prescription of palliative RT was 30 gray in 10 fraction, but when it was entered into the system, it was entered as 20 gray 10 fraction. So these are the methods. So recorded PP detection, role, and location of individual identifying, and the type of problematic plan presentation after the charted round was started was all recorded. And it also recorded the detectability and severity. Detectability, can you see this chart? You can see that in the right fag end of the corner, the wrong dose, very wrong dose and dose distribution, location and volume, according to severity, was very high. And these were the estimated probability of failure, which was going undetected, was more than 20%, which is all catastrophic failures, inevitable. And this failure rate, which was going undetected, was more than 20%, which is very, very significant. So if you see, these are the results. This results obviously says, pointing out there are a lot of errors that was not detected. It may be related to the chart rounds, may be related to the fatigability or the number of cases as we have already identified. But we can see that inadequate target coverage and certain things like dose and fractionation pattern, like for example, 30 gray 10 fraction or 20 gray 5 fraction, the incorrect pattern was still presented at 8th minute. It was not at the fag end. It was very, very early in a chart round, but still it went undetected, which is going to be a grossly catastrophic.
Dr. Mathangi, sorry for interruption. We are already behind schedule, and your allotted time for the first paper is over. Please conclude and move to the second paper. 7 minutes for one.
I will just do the conclusion, sir. So the detection rate was only 50%, and it was more related to the earlier timing. And as the number of weeks people became more aware that these things can happen. So it was only 55%. So we should always remember that chart rounds is not a foolproof technique, and we should have more techniques to detect the error detection. So future rounds can be shorter disease sites. We can have disease site specific rounds, and written patient summaries has to be clearly defined there, and standardized case presentation. Thank you.